Welcome to our second video on joint pain. Let's begin. In this lecture, we will discuss carpal tunnel syndrome, knee pain, tendinitis, and bursitis. Here's an overview slide of the topics we're going to discuss for carpal tunnel syndrome. Carpal tunnel syndrome is an entrapment of the median nerve in the carpal tunnel. Let's recall the anatomy of the carpal tunnel. Here you see a cross-section of the carpal tunnel. The carpal tunnel contains the tendons of flexor digitorum superficialis muscles, flexor digitorum profundus muscles, and the flexor pollicis longus muscle. The carpal tunnel also contains the median nerve. Entrapment of the median nerve causes carpal tunnel syndrome. There are multiple different etiologies of carpal tunnel syndrome. Pregnancy can induce it due to edema in the enclosed space. Rheumatoid arthritis results in pannus formation, which can compress the median nerve. Hypothyroidism can cause deposition of glycosaminoglycans, which also compress the median nerve. Diabetic neuropathy can directly damage the median nerve due to oxidative stress and demyelination. Acromegaly enlarges the carpal bones, which can then damage the median nerve. Dialysis-related amyloidosis causes accumulation of beta-2 microglobulin in the carpal tunnel. This will compress the median nerve. Finally, carpal tunnel syndrome may also be caused by repetitive use of the hand. Carpal tunnel syndrome presents with paresthesia, pain, and numbness in the lateral 3½ fingers, that is, the thumb, index finger, middle finger, and the radial half of the ring finger. This is because the skin over these areas is innervated by the median nerve. Carpal tunnel syndrome also results in thenar atrophy because the median nerve normally innervates the thenar muscles. Thenar atrophy is also known as the ape hand because apes have flat thenar muscles. Thenar atrophy will result in the patient's inability to oppose the thumb against the other fingers. This is because the opponens pollicis muscle is part of the thenar eminence. Importantly, there will be no loss of sensation on the thenar eminence. The thenar eminence is normally innervated by the palmar cutaneous branch of the median nerve, which enters the hand external to the carpal tunnel. This is why carpal tunnel syndrome does not affect the skin over the thenar eminence. Here you see the illustration of sensory innervation to the median nerve. Please note that the median nerve innervates the lateral 3½ fingers, that is, the thumb, index finger, middle finger, and the lateral half of the ring finger on the palmar side. On the dorsal side, the median nerve innervates the fingertips of the thumb, index finger, middle, and lateral half of the ring finger. These are two images comparing the normal and atrophic thenar eminences. On the left image, you can see the normal thenar eminence. On the right image, you can see atrophic thenar eminence, which is characteristic of carpal tunnel syndrome. Diagnosis of carpal tunnel syndrome starts with physical exam maneuvers. Tinel sign is percussion of the palmar wrist surface that causes tingling in the median nerve distribution. Phelan sign is 90-degree flexion of both wrists against one another that causes tingling in the median nerve distribution. Carpal tunnel syndrome can be confirmed by the nerve conduction studies. Here you see Tinel sign. Percussion of the palmar wrist surface causes tingling of the median nerve distribution, which suggests carpal tunnel syndrome. And this is Phelan sign. 90 degrees flexion of both wrists against one another causes tingling in the median nerve distribution, which is also characteristic of carpal tunnel. It's high yield to know the sequence of interventions for carpal tunnel syndrome. Management of this syndrome starts with immobilization of the wrist with a thumb spica splint. If the splint does not help, then intra-articular steroids can be prescribed. Refractory cases are treated with surgical release of the transverse carpal ligament. A 31-year-old G1P0 woman at 37 weeks of gestation comes to the physician with right-sided hand pain. The physical exam reveals paresthesia in the right thumb, index finger, middle finger, and lateral half of the ring finger. The thenar eminence is atrophied. Which two physical exam maneuvers will help confirm this patient's underlying condition? This pregnant woman has paresthesias in the right thumb, index finger, middle finger, and lateral half of the ring finger. The thenar eminence is atrophied. These findings are consistent with the diagnosis of carpal tunnel syndrome. Carpal tunnel syndrome was likely induced by pregnancy-related edema in this patient. The two physical exam maneuvers which help confirm carpal tunnel syndrome include Tinel sign and Phelan sign. Let's move on to knee pain. Here's an overview slide of the topics we're going to discuss for knee pain. Knee pain is pain in the area of knee due to non-inflammatory, inflammatory, infectious, or systemic causes. Non-inflammatory causes of knee pain include osteoarthritis. Inflammatory diseases responsible for knee pain are pseudogout, also known as acute calcium pyrophosphate deposition disease, and gout. Septic arthritis is an infectious cause of knee pain. Systemic causes of knee pain include systemic lupus erythematosus, rheumatoid arthritis, and seronegative spondyloarthritis, to name a few. Knee pain may be accompanied by erythema, warmth, and swelling in case of inflammatory and infectious conditions. Extra-articular signs and symptoms depend on specific causes of knee pain. Fever may accompany knee pain in inflammatory and infectious etiologies and in systemic diseases. Tophus formation is pathognomonic for gout. Diarrhea may accompany inflammatory bowel disease-associated arthritis. Rash is common in systemic lupus erythematosus. Nail changes along with knee pain may be seen with psoriatic arthritis. A 41-year-old woman presents with bilateral knee pain and swelling for the past month. She also experiences the pain in her metacarpophalangeal and proximal interphalangeal joints. Physical exam reveals a rash over her nose, sparing the nasolabial folds. Painless mouth ulcers are also detected. A complete blood count shows pancytopenia. What is the most likely cause of this patient's knee pain? The patient presents with swelling and knee pain. She also experiences pain in her metacarpophalangeal and proximal interphalangeal joints. Physical exam reveals a rash over her nose, sparing the nasolabial folds. Painless mouth ulcers are also detected. A complete blood count shows pancytopenia. All these findings are consistent with the diagnosis of systemic lupus erythematosus. So, systemic lupus erythematosus is the most likely underlying cause of the patient's knee pain. Diagnosis of knee pain starts with a physical exam of the knee. One should be alert for alarming signs like warmth, erythema, and swelling. A complete blood count and blood culture are done if septic arthritis is suspected. Arthrocentesis allows for synovial fluid analysis for microbes and crystals. Knee X-ray or MRI may be necessary to observe the bones, menisci, and soft tissues around the joint. Arthroscopy is an invasive procedure used to observe the synovial space from the inside. This is what knee joint looks like on MRI. Please note the effusion in the knee joint, which could be present in a variety of conditions causing knee pain. Management of knee pain depends on the specific cause. Pain control can be achieved either with acetaminophen or NSAIDs. Septic arthritis requires antibiotics and joint drainage. Intra-articular or systemic corticosteroids can be used for crystal-induced arthritis and autoimmune diseases. Colchicine is also used for crystal-induced arthritis. Lastly, we'll talk about tendinitis and bursitis. Here's an overview slide of the topics we're going to discuss for tendinitis and bursitis. As the name implies, tendinitis is inflammation of the muscle tendon, while bursitis is inflammation of the bursa. Let's recall what the tendon and bursa are. Tendon is the fibrous cord that attaches muscle to bone. Bursa, on the other hand, is a sac-like structure filled with synovial fluid that cushions the areas where bone is close to the skin. This is how the bursa decreases friction and preserves bones and tendons. Tendinitis is most commonly caused by muscle overuse with repetitive movements. Corticosteroid use may also cause tendinitis or tendon rupture. This is because corticosteroids inhibit collagen synthesis and weaken the tendons. Bursitis, on the other hand, can be caused by a mechanical injury of the bursa. For example, prolonged kneeling can damage the prepatellar bursa, causing prepatellar bursitis. Bursitis may also be caused by crystal deposition in the bursa. This happens in gout and pseudogout. Finally, bursal infection will cause septic bursitis. Tendinitis presents with a painful and palpable cord under the skin. Pain is also present with movement of the muscle attached to the affected tendon. Bursitis, on the other hand, presents with a swollen and painful mass under the skin. Erythema and warmth may accompany bursitis. Diagnosis of tendinitis is mostly clinical. MRI can be done to identify the soft tissue swelling around the inflamed tendon, but this is not routinely used. Similarly, bursitis is mostly a clinical diagnosis. However, ultrasound can show excessive fluid accumulation in the bursa. Aspiration of bursal fluid is considered in cases of suspected crystal-induced or septic bursitis. Tendinitis is treated with acetaminophen or NSAIDs. Cold compresses and rest of the affected tendon and muscle are also beneficial. Bursitis can be managed with cold compresses. Antibiotics are needed only if septic bursitis is suspected. Here's a table summarizing the topics discussed in this lecture. Please pause the video and take a moment to consider this table. A 65-year-old man presents to the physician complaining of progressively worsening left hand pain. He has hypertensive chronic kidney disease and has been on dialysis for 10 years. At the previous visit, he complained of paresthesia in the left thumb, index finger, middle finger, and lateral half of the ring finger. He was prescribed the thumb spica splint, but his symptoms have not improved since then. His vital signs include a temperature of 30 to 7 degrees Celsius, a blood pressure of 150/90, a heart rate of 81, and respiratory rate of 14. Physical exam reveals left thenar atrophy. Which of the following is the best next step in the management of this patient? A. IV corticosteroid injection. B. Local corticosteroid injection. C. Oral corticosteroid. Or D. Surgical decompression. The patient presents with progressively worsening left hand pain. At the previous visit, he complained of paresthesia in the left thumb, index finger, middle finger, and lateral half of the ring finger. These findings are consistent with the diagnosis of carpal tunnel syndrome. He has hypertensive chronic kidney disease and has been on dialysis for 10 years. Therefore, the carpal tunnel syndrome is likely caused by dialysis-related amyloidosis in this patient. He was prescribed the thumb spica splint, but his symptoms have not improved since then. The best next step in the management of the carpal tunnel syndrome after thumb spica splint is ineffective is local corticosteroid injections. Therefore, the correct answer is B. Here's a slide reminding us of the sequential management of carpal tunnel syndrome. Let's discuss why the other options are incorrect. Option A and C, intravenous and oral corticosteroids, are incorrect because they are not used in the management of carpal tunnel syndrome. Option D, surgical decompression, is incorrect because it's performed as the last resort after the thumb spica splint and local corticosteroid injection. And that concludes this section.